I'm also very proud that we have about almost 130,000 followers on our YouTube channel, which is really amazing because this Grand Rounds is probably the most attended Grand Rounds in the world, I would say. And we love to share our information, our knowledge, and it really is very satisfying and gratifying. Last week, I was on my way to the American Society of Echocardiography, and I was called because of certain receptions and acknowledgments, and I was reminded that this is my 40th year as faculty here at Houston Methodist. What a journey. I'm so proud of this institution, our pathway together, and what we've accomplished, not only in education, but also in research and clinical care. Usually I start, this series of Grand Rounds with a certain topic. It could be healthcare in the United States. It could be topics in medicine that are dear to my heart. Usually it's valvular heart disease. And I thought today is to go through the mitral valve and mitral regurgitation. I know we will have another topic with Dr. Lowry and associates regarding various repair techniques and how much have we really come a long way over the years. The mitral valve is amazing. Actually, it is the most prevalent disease as we grow older. And the apparatus is really mind-boggling in a way. The ventricle has to generate very decent pressure above 100 millimeters of mercury. The apparatus is quite complex. Even an AI may not have come up with this structure of the mitral valve. And most of the time it's very competent and it does the job very well. The annulus, the valve itself, I know we always think about the valve itself, but certainly the support apparatus, the chordae tendineae, the papillary muscles, all of them work in synchrony. I wanted to share with you also some information that I got. One is about the mitral valve itself. This is Dr. Vesalius, an anatomist and physician who actually named the valve, and he just lived 50 years only at the University of Padua. And the University of Padua actually is famous for many things. One is probably among the oldest medical schools in the world. Two, if you take a look at the theater there on the right side, and this is where dissections were done. Actually, I visited. Medical students would stand. There's no sitting for them. They would just stand all in rows watching the dissection. And interestingly enough, dissections were not permitted. So if there was a police that comes in, basically they flip the patient back so that they camouflage that indeed there was a dissection going on. So that was the description back then, 1500s. Go forward to 1960, the first time you could visualize at least what would look like something in motion, the mitral valve. This is by Dr. Inge Edler, who was honored at the American Society of Echocardiography, again because of the 50th year of the American Society of Echocardiography this past week. And that was an A mode, and I don't think we can recognize what a mitral valve would look like just from an A mode. I'll give that to our fellows nowadays. It'll be hard to. And with him is Dr. Carl Hertz, and they collaborated actually to have the first applications of ultrasound to the heart. So almost 500 years down the line for the first time to us to be able to image. And Dr. Edler would be amazed, actually, that we could see with the same technology that he proposed, that you could see the mitral valve in motion, in 3D nowadays. And actually, if you take a look at all the imaging modalities that we have nowadays, a transesophageal 3D is probably the best evaluation and modality to take a look at the mitral valve, be it spatial in addition to temporal resolution if you want to look seriously at the mitral valve and its properties and really what happens during systole. I know Dr. Lowry mentions that significantly, which I re-emphasize that if you have to have a competent mitral valve, you need at least about 8 millimeter to almost a centimeter of apposition between the leaflets. The leaflets are not linear. They have rugae, they have different shapes, and for you to have a complete apposition and sealing of the mitral valve, you need to have enough. So you can imagine already that if the ventricle is dilated for secondary mitral regurgitation, that if you don't have enough apposition, you will have significant regurgitation. And you could tell already that indeed, if you change the geometry of the ventricle or the atrium in secondary mitral regurgitation, you will have better apposition. And that's why I think this is very important before major interventions occur. And this is an example here of primary MR, prolapse of the posterior leaflet. You could see a nice eccentric jet that clinically can simulate an aortic stenosis murmur, secondary MR. And I think it's important to review these areas of secondary MR. Early on, a lot of emphasis on ventricular secondary mitral regurgitation, where the ventricle is so deformed, but it doesn't have to be necessarily enlarged. You could have an inferior infarction, infero-posterior infarction, papillary muscle dysfunction, and you'll have secondary mitral regurgitation. But most often what we see is the ventricle is quite large. Another entity that I think has more surfaced, I would say, over the past 5 or plus years is atrial secondary mitral regurgitation, where the atrium is significantly enlarged and the ventricle is really not that large. And actually, I was honored to be asked to write an expert and chair an expert panel viewpoint as to atrial mitral regurgitation compared to ventricular mitral regurgitation. Interestingly enough, in any of these secondary regurgitation, you will see tethering of the mitral leaflet. And you see that arrow there, normally the mitral valve has to be concave. This is where you don't have tethering on the left upper that you could see there. But be it atrial in the middle or secondary ventricular regurgitation, you will have significant tethering of that area and straightening of the valve. Notice that in atrial mitral regurgitation, the atrium is rather huge. The entities are atrial fibrillation, chronic atrial fibrillation, or HFpEF, or a combination of such. And I think these are the characteristics that we published a couple of years ago, and the differentiation between atrial and ventricular. The ventricle size and geometry, no regional abnormalities, is usually normal or just mildly enlarged. Preserved regional global function. The annulus is very dilated in those situations, and the atrium is also dilated. The mitral valve is otherwise normal. Interestingly enough, for us to think about also from a pathophysiology point of view, is that in red are the patients who have atrial mitral regurgitation. As you know, the mitral valve actually is a dynamic. It can grow. But if the mitral valve is not as large as the annulus large, so the ratio is altered that you could see in those red. And if you don't have enough mitral valve structure, you won't have enough apposition when you have an alveolar dilatation, and therefore you'll have secondary atrial mitral regurgitation. Prevalence-wise, less than ventricular. Severity is usually less, but obviously there are situations where you could have severe atrial mitral regurgitation, and there's a lot of discrepancy in the literature as to the criteria, and that's why we're not emphasizing it today till things get a little better under, let's see here, better described. Okay. How about primary mitral regurgitation? Primary myxomatous degeneration, that's the most common. Obviously, you can have other etiologies of it. We're not going to go through them. And I think a little caveat here about Dr. Barlow, because it's called Barlow syndrome, where you have bilateral, right, bileaflet mitral valve regurgitation and thickening and myxomatous degeneration. You need to know that prior to 1960, a click murmur were thought to be outside the heart. And 1960 is not, too far out. Oh, I was born then. Actually, he followed some of his patients, and he followed one of his patients, and autopsy, the mitral valve was indeed very abnormal. And to many of our academic physicians here, fellows, don't be discouraged if your paper is not accepted. And certainly the first manuscript was labeled as too assertive, that indeed there was problem with the mitral valve. And he had a connection, Maryland State Medical Journal, where his friend was there, sub-editor, so he was able to alter it a bit and at least get it there. And I think the rest is history after that, which is really very, very interesting. And what is this disease about? Obviously in Barlow's disease, mitral valve is myxomatous, is very thick. You can have fibroelastic deficiency usually later on in life. And I think it's important in this pathology picture, if you will, compared to normal. The spongiosa as well as the elastin are really very deformed. And the mitral valve, as we all know, is very thick with infiltration of the mitral valve apparatus. But the one I want to show you also is in the left lower there that you could see a chordae tendini. Actually, the chords are very abnormal in mitral valve disease, and this is why you will have rupture of the valve. It is not the problem necessarily of the valve itself, it's also the support apparatus. And when you have infiltration of such, thickening, fragility of such, and you will see later on that there is more strain on the mitral valve during every beat that this valve undergoes, you'll have a lot of abnormalities and a lot of obviously rupture that can happen. If you look at the mechano-biology of the mitral valve, this is a stress-strain relationship. And normally in the valve, and you could see there up in red, you can have about 10% deformation of the mitral valve. So every beat, the mitral valve with 100, 120, 130, 140 millimeters of mercury, the valve will stretch. And you'll have normally about 10%. Obviously, if you put more stress on it, you'll have more alignment, and obviously you'll deform it, but this is not physiologic. So physiologically is about 10% or so of strain of the valve. And we asked a question a few years ago, my goodness, it's been like 10, 15 years ago, can we do this evaluation clinically? Particularly nowadays that we have transesophageal and echocardiography and 3D. And what are the determinants? Because before that, actually, all the evaluations are done in animal models with beaded crystals, etc., that you could put on the mitral valve to try to understand it. And actually, we were with an amazing collaboration between the University of Houston Mathematics Department. You could see Dr. Lowry here, more hair, doesn't have the tincture of more time. Dr. Lowry, you were as active then as now. Dr. El Talawi, who we call Mr. Mitral Valve. Dr. Ben Zikri, who I saw last week, and she's in Israel now and doing very well. So what we did is actually took our 3D transesophageal echocardiography and ran them through all the mathematics clinics to look at deformation. And actually, we were able to do that and have a map, a heat map of the mitral valve. And in more red, yellow is higher strain and mitral valve prolapse. And this is a depiction actually of a mitral valve that has mitral valve prolapse in it. And you could see the deformation in systole. And interestingly enough, is that the deformation that you will see there are more prominent in the posterior leaflet. This is the normal valve on the left and a mitral valve with mitral valve regurgitation on the right. Much more strain, and be it in normal or an abnormal disease, mitral valve strain is much more in the posterior leaflet, which is smaller compared to the anterior leaflet. Here, this is mitral valve strain and mitral valve prolapse versus normal. And the harder population was to get the one in the middle, because you rarely see mitral valve prolapse per se without mitral regurgitation. So we needed a control just to see whether this is a relation to the regurgitation or not. Indeed, those patients with MVP and regurgitation have more strain compared to the ones with mitral valve prolapse without regurgitation and compared to normal. And it relates also to thickness of the valve. And that's what you would expect that the thicker the valve, you have more strain, and the deformation could be almost 20%, just imagine. And this is leaflet. So you could think also, and it's very hard to look at deformation of the chordae tendineae themselves, because the chordae tendineae themselves is very hard really to measure. You know that in mitral valve prolapse, actually, the papillary muscle and the chordae go in the wrong direction. They go towards the atrium as opposed towards the ventricle, so we know they're stretched significantly. And what happens after resection, after repair of the mitral valve, this is Dr. Lowry's work here, you could see a continuous annuloplasty of the valve, and strain is significantly reduced. So the question is, how do these relate to longevity of the valve after you do the repair? You could see reduction in posterior leaflet strain in addition to the anterior leaflet strain. So in conclusion here, regarding these data that we've accumulated over time, one is the posterior leaflet has much more strain, and the question is, could this be why we see so much more calcifications in the posterior leaflet as individuals grow, or you have kidney disease and other diseases, which is also a marker of bad prognosis. What is the outcome after repair? Is a repair better if you have normalization of strain? And I think this is all work in progress, and we're trying nowadays to do this with cardiac MRI, so you don't have to go to transesophageal echocardiography. I know it's more challenging. The best so far is with TEE. Now, if the valve is incompetent, right? If there is mitral regurgitation, how do we assess it? And I was also privileged to chair actually the first document back in 2003, and this is the update in 2017. Time flies, it's 8 years ago. And I'm not sure I'm gonna be asked, but I'm not sure I'm gonna to revise this document. But the good thing is that for mitral regurgitation per se, from a quantitation point of view, I think the criteria are still about the same. No major changes in this. And what do we look for? Well, from an imager point of view, which obviously relates to the clinician and the interventionalist and the surgeon, we want to relay from an imager point of view, what is the etiology? What's the mechanism of regurgitation? Use our integrative approach as much as possible, because it's really hard to quantitate in all cases. And the emphasis on a new entity, not new, but this is Dr. Barlow's disease, right? When you have non-holosystolic mitral regurgitation, and the importance of cardiac MRI, which was not in the first iteration of these guidelines back in 2003. This is the Carpentier classification. We're not going to go through it, but obviously, most importantly, we don't have to remember type 1, 2, and 3. Most importantly is to relate in your evaluation and in your interpretation, what is the underlying mechanism of this. And TEE is very important. 3D is very important to localize unusual abnormalities, particularly commissural areas, and to guide interventions. There is a new specialty nowadays of interventional imaging in the catheterization laboratory, which is really very important with the dawn of catheter-based procedures. But you could do actually quite a few things without even 3D, but I think it complements what you see. And even some of the changes in 3D nowadays, it's almost like you're looking at the valve per se, and I think Dr. Edler would be in awe looking at this mitral valve. When you see a flail of leaflet, it's almost like you're seeing it at pathology. So how do we evaluate such? You look at the valve. In significant MR, I'm not talking about acute mitral regurgitation, in significant mitral regurgitation, chronic, you have to have remodeling of the ventricle and the atrium. There's variability in interpretation, echocardiography. Once you go beyond medical centers like this, a lot of variability. And you have to be very careful when somebody is called a severe mitral regurgitation, somebody who is very stable without dilatation of the ventricle or the atrium. We look at color Doppler, obviously evaluate that with its 3 components. We look at the hemodynamics, quantitate regurgitant volume and regurgitant fraction, and look at continuous wave Doppler from a hemodynamics point of view. So individuals in the echo field has to have a systematic view of how do you evaluate such. This is color Doppler. We look at flow convergence. in the ventricular side coming into the smallest area, which is the vena contracta, and in the receiving chamber, which is the left atrium. It could be in any direction. It could be very eccentric, could be central. And this is an example from the guidelines. Now, notice, interestingly enough, severe central versus severe eccentric look very different to the eye. For somebody who's not an expert, please don't only look at what's happening in the receiving chamber. Look also at what's happening in flow conversions and the vena contracta. So you have to look at these three. The direction of the jet may tell you about the etiology, meaning there is one of the valve versus another that is not coapting symmetrically. Okay, so my advice is first look at what's going on, ventricle and vena contracta, and then you can emphasize if you want. So this is very important. So flow conversions, PISA, yes, you could quantitate effective regurgitant orifice area and flow through those, and I think this is important. That's probably most commonly used globally in quantitation, less often volumetric quantitation. And these are the criteria for moderate or severe regurgitation. Once you start beyond 0.2, you have to kind of be careful a little bit. At least at 0.4 centimeter squared, this is rather severe, but this is the overall prognosis of this, and this is many years ago, and I think that has really withstood the dead of time. But there is a caveat. There's a caveat to flow conversions. It can be very eccentric. It can be difficult. It is variable during time. The assumption is a hemispheric geometry and may not work as well in secondary MR. We always use it at least semi-quantitatively. Basically, to tell you that if you have a diameter of vena contracta greater than 0.9 or 1 centimeter, you're dealing with severe mitral regurgitation. And the biggest caution is the last one, caution in non-holosystolic mitral regurgitation. This is mitral regurg that occurs later in systole. Now, your eye may not be initiated to the color Doppler, but take a look at continuous wave Doppler just below. The mitral regurgitation starts later. This is the QRS complex here. Nothing, no MR at first, and then later mitral regurgitation. So you know already that it is not happening throughout systole. It's almost in your mind, although you cannot quantitate it well, that it will be half of what you think. Almost half of what you think. This is from the guidelines itself. You cannot use color Doppler measurement severity, jet, and all of them alone in this late systolic mitral regurgitation, because you'll be fooled. You will overestimate the severity, and we've seen this from many referrals. So I think this is the caution for you. And the data actually substantiates it. It's almost half of what you see, meaning the regurgitant volume is almost half if you have holosystolic versus non-holosystolic mitral regurgitation. The left atrial volume is less, PA systolic pressure is less, LV volume is less, and the prognosis is better. So keep those in mind. If you want to use color Doppler, the only thing that you could use is the regurgitant volume, which the VTI for the echocardiographer is lower, so I think that's the only thing. And in those situations, you need to quantitate by other modes. And similarly with multiple jets that you're really not sure about. And this is volumetric quantitation of basically looking at volume, either through the mitral valve or total output of the ventricle compared to what goes systemically, either in the LV outflow tract or in the RV outflow tract. And you can come up with regurgitant volume, regurgitant fraction. And this is the algorithm from the American Society of Echocardiography that was proposed, and I think is still valid at this stage. There's no tweaking to it. The only tweak is, do we need all these specific criteria for us to assess severe mitral regurgitation? And Dr. Al-Talawi actually has presented just at the American Society of Echocardiography, and hopefully you'll see this in print sometime next year, that indeed each one of them is really specific, and you may not need all of them to really come up with severity of regurgitation. So I think, stay tuned regarding that. MRI is very important in this disease and other valvular heart disease. You could see very nicely on the left there, Barlow's disease, both leaflets are billowing back towards the left atrium, and these are the other flail secondary MR. It is very quantitative. Yes, it is a gold standard, but that is not without fault, right? Meaning that there may be some variability there. Depends on the lab and depends how compulsive you are in getting regurgitant volume and regurgitant fraction. And the way it is quantitated is called the indirect method. Why? Because you compare the total output of the ventricle to phase contrast that is going systemically, either in the aorta or the RV outflow tract. This is not in the guideline, but this is my approach, meaning if I need more help from my transthoracic echocardiography, when do I lean toward transesophageal, or when do I lean towards a cardiac MRI? Number one, if you're thinking about endocarditis, TE is your definite way, particularly if the vegetations are small, very mobile. It's a problem for any other imaging modality, so transesophageal is the way to go. If you have atrial fibrillation with a lot of variability, if you have major susceptibility artifact, prosthetic valves, and obviously when you need this at the bedside as opposed to taking them to the laboratory. When you need more quantitation, I think cardiac MRI is meaning I know what the disease is. I'm really not sure how severe it is. There is some remodeling, but really not sure. Eccentric jets, multiple jets, I think this is really the way to go. And secondary MR, obviously, to assess viability at the same time. And I think these are very important. So my view on this is they are complementary. Obviously, echocardiography is usually the first line to evaluate patients. Not every patient obviously has severe mitral regurgitation, right? And in select patients, yes, we will refer them to cardiac MRI for further evaluation. There is variability in quantitation, more for echo, less for MRI, but none of them are no variability. And then maybe you may find some discordant findings between echocardiography and MRI, and it may occur in about 10% of cases or so. And that has been consistent in our lab and other laboratories. I think you as a clinician need to know when to refer somebody to either one of the modalities. I think it's very important. And the last one is, if you're really not sure, being an echocardiographer or a cardiac MRI, as to there are technical issues, etc., clinicians are depending on you. And I think we have to be transparent as to if there is difficulty or such, and maybe in an echocardiogram is suggest a next step if you're really concerned. And the reason for it is, as opposed to back in the 80s and 90s, we have multiple modalities for us to be able to try to assess and nail down underlying pathology in addition to severity of disease. So I think this is crucial. So what's new in this concept? New, I think, is, and this is just over the past, I would say 3 to 4 years, is Barlow's disease has also some new concepts. We as clinicians have seen and continue to see patients with typical bileaflet prolapse, where the ventricle or the atrium are larger than expected for the degree of regurgitation that you see. In the past has been called Barlow's cardiomyopathy. They may still be some of it, and the reason for it is, as the Padua team, the anatomy team have described a few years ago, there are actually fibrosis, there are areas of fibrosis, stress in the ventricle, so you could have cardiomyopathy on top. But I think, as you will see here, is Dr. Deepan Shah, who directs our Cardiovascular Imaging Institute, and Dr. El Talawi looked at this and trying to understand, is this prolapse volume depicted in blue, in addition to the mitral, the actual true regurgitation of the valve, is that important from a remodeling of the ventricle? It's almost like an aneurysm or a pouch or something else that is causing the volume overload in addition to what the mitral regurgitation does. And actually the data bears this. And this is data published a few years ago now from Dr. El Talawi and Dr. Shah. Bottom line is, if you take a look at the x-axis here, MR greater than 50 ml, basically decreasing severity of mitral regurgitation. On the other axis is the prolapse volume. If the prolapse volume is significant for any degree of mitral regurgitation, the ventricle is larger. Actually, it accounts for this volume overload. And if you take a look at the data itself, the best one of relation of end-diastolic volume to the severity of this regurgitation is when you add the mitral regurgitation on the prolapse volume. And actually, the laboratory nowadays in cardiac MRI reports both, which is very important because actually I have patients who I've referred, the ventricle is quite large, the MR is moderate, and the prolapse volume is moderate, and you add them together, it becomes severe, and the ventricle has shrunken down very nicely. So it's not a pure cardiomyopathy, right? So I think this concept is very important, and it's a new concept, and it will change. This is grade reclassification. Obviously, if the prolapse volume is 15, 20 ml, it will change the classification of the severity of regurgitation from either mild to moderate or moderate to severe, etc. This is ACC Focused Update 2020. I mean, time flies, right? And this is, 5 years ago. Is it still valid? And I think overall it's valid. The question is, where does TEER, where does the other things, but even in 2020, TEER and other repair technologies or total replacement with a catheter has been addressed. We talked about identify and define and assess the severity of the regurgitation. How do we treat it, right? Obviously, we talked about secondary and primary MR and all these. So let's go through some of these. Why treat it? What is the risk, all right? It's not only left ventricular dysfunction or atrial fibrillation. Obviously, excessive cardiac remodeling, ventricle, in natural history of this disease, hopefully we don't see too much natural history of those anymore. Ventricle gets big, LV failure, there's myocardial fibrosis, more often in mitral valve, degenerative mitral valve disease. There's pulmonary hypertension, RV failure, tricuspid regurgitation, atrial fibrillation with the need of anticoagulation, and sudden cardiac death particularly, I think, can be devastating, and I've seen some of them in younger individuals with typical Barlow disease. So I think this is really very important. And the beauty of it is our surgeons have really now done an amazing job in repair of this valve. So if it is pure degenerative mitral regurgitation, you could repair it in almost 100% of the cases, greater than 95%. And this is shown in the team's approach, right? And we're privileged, obviously, to have had amazing surgeons, throughout the years. This is ACC guidelines, 2020, and I know that they're being revised. Okay. Personally, I was surprised that the biggest challenge is not in the symptomatic individual in advanced disease. The biggest challenge is when do you operate on somebody who's asymptomatic. And I was surprised. I talked to Rick Nishimura, who's currently retired and does educational activities, and Dr. Otto. In the past, there used to be atrial fibrillation, there used to be pulmonary hypertension, never been actually left atrium size. But the only thing you see is a linear measurement, right, of LV size and ejection fraction. Remember this as opposed to aortic regurgitation. Anything function-wise that you see should be on the higher side, greater than 60%, even preferably 65% or so, because you will have reduction in that function. So the question, are there any other signs that are important? This is from large registry data from Mayo Clinic as to the importance of a very big left atrium. And a very big left atrium, obviously, is not necessarily ventricular function that we're talking about. There's anything that goes on also with the left atrium, and also what goes on in pulmonary vasculature, pulmonary hypertension, atrial fibrillation, many other things. So on the left is sinus rhythm, on the right side is atrial fibrillation. Even in atrial fibrillation, left atrial size greater than 60 ml, which is really severe, not moderate, very severe, could be a factor for us to consider in the evaluation of patients. Another thing that you're not going to see it yet in the guidelines is global longitudinal strain, right? And this is an echocardiographic feature, not global longitudinal strain. But I want to share with you that this cutoff of global longitudinal strain is greater than 21. Okay? Normal is up to 17. Greater than 21, which goes along almost with your ejection fraction of greater than 60, 65. So basically, you want a hyper-functioning ventricle, right? And below that, and the reason for it is actually there is already some myocardial damage. 2 weeks ago, I was at European Society of Cardiology, and actually, they rolled out their latest guidelines for valvular heart disease. So since we're talking about mitral valve disease, this is for severe primary mitral regurgitation, and the asymptomatic is on your left of your screen. You may not see it all. EF and systolic dimension are still the same, they're not different. But I'm glad to see that there is a category for atrial fibrillation, as you could see right here, systolic pulmonary artery pressure of greater than 50, LA volume greater than 60, and concomitant secondary moderate tricuspid regurgitation. If you have 3 of those, it's a class 1 indication, on top of, obviously, severe mitral regurgitation you start with. And part of the reason, as I mentioned to you, is it's not only the ventricle, is what are we talking about this individual patient? If we want to try to keep them off atrial fibrillation, anticoagulation, many other things, pulmonary hypertension, RV dysfunction. And the beauty of it, all this is in the context of somebody that we can repair, right? So as you could see, much more aggressive stance in mitral regurgitation repair as opposed to aortic regurgitation. I know we'll have a session on aortic regurgitation where, we're not as aggressive. If we could repair all the valves in the aortic valve, then we would have the same stance going forward. Another thing that cardiac MRI can tell us is about regional fibrosis. Yes, there are data also on ECV, the extracellular volume index, etc., but I think regional abnormalities, fibrosis, I mentioned that to you. The Padua group had demonstrated that at pathology, and nowadays, obviously, we have cardiac MRI to be able to assess that. And this is data from Dr. Shah's laboratory here. In blue are patients with mitral valve prolapse, classified as to the severity of mitral regurgitation. So for people with much more significant mitral regurgitation, they have almost 50% incidence of regional abnormalities in mitral valve in fibrosis, which obviously adds to their risk and could be also an arrhythmogenic risk, right? So it may not be one-on-one, excuse me, but I think it will add to the risk. And I will have a shout out for Dr. Shah because before all the issues with NIH nowadays, et cetera, he was able to land a big NIH R01 grant about sudden cardiac death, risk assessment, and mechanisms of arrhythmic mitral valve prolapse. And I think the view is very comprehensive. He and his collaborators will look at deep phenotyping of mitral valve prolapse patients, every way, shape or form that we could do with current technology, collaboration across the street with Baylor College of Medicine and Christy Ballantyne to evaluate the relationships of circulating blood biomarkers with patients who have fibrosis or have significant arrhythmias. And last, I think to have a big registry aiming for 2,000 plus patients regarding this disease, mitral valve, prolapse disease and cardiac MRI. And I think this would be across many institutions, and I think will be amazing, deep, and really to go forward with this. So what are some of the unanswered questions that we have still in primary mitral regurgitation? If you tell me, are there going to be randomized trials to answer some of these questions, I really doubt it, okay? Because nowadays, we are pushing, obviously, for an earlier intervention for most of these diseases. So it's going to be big registries, hopefully across institutions. And the questions are LV volume versus linear dimensions. And linear dimensions are very variable. Role of LV strain. You may think it may be redundant to ejection fraction, that could be. Prolapse volume in Barlow disease. Well, we don't know much about that. We know from obviously our data here. Cardiac MRI parameters, the importance of fibrosis, should you operate on earlier? I think, Dr. Shah's work, I think, hopefully will enlighten that, and risk stratifications for arrhythmias. Traditionally, our approach for primary MR is to have a surgical intervention. And a surgical intervention with repair has been really phenomenal, with repair rates in the appropriate patients with degenerative MR better than 95% or so. And these are the data, including from Dr. David, Dr. Lowry, and the others. And I think the survival of patients, freedom of reoperation of mitral valve is really in the patient, obviously, who has lower risk for disease, not severe risk. And with the advent also of transcatheter approaches, I mean, the field is amazing nowadays, not only for a TEER approach, but also for valve replacement. Where does the imager come into play? And actually even our interventional cardiologists and surgeons play around with this, because this is very important. You put a valve and it is maybe quite bulky. Major problem is reducing the LV outflow tract. And in the past, we would just put it there, but obviously many things are dynamic, but nowadays actually, hopefully with computer modeling, you should be able to see what the effect would be, not only on the annulus, and hopefully you'll have some tensile strengths in it and so many other things, and see what happens to the LV outflow tract. Interesting enough, obviously, if you use edge-to-edge repair, you may end up with various residuals, right? And this is at times could be quite tricky from an echocardiographer point of view, who's in the catheterization laboratory, very eccentric jets, at times multiple ones. Again, I was privileged to chair this document back in about almost 5-6 years ago now, regarding how do you evaluate such. And color Doppler and pulmonary veins are very important in the catheterization laboratory. And this is a pre on top and post. And you could see the changes. Number one, if you see a quote-unquote resurrection of the systolic wave, and you could see S there in the pulmonary veins, you'd be certainly very happy, and the patient will be very happy at the same time. Color Doppler, you could measure a vena contracta area if you want to. And this is data from our Dr. Sachin Goel, who is the director of our interventional structural heart disease. And I think this is comprehensive because it doesn't only look at what echo Doppler does, but also what the residual is regarding left atrial pressure. So if you reduce the MR significantly, if you have an improvement in the systolic wave, and if you reduce the mean left atrial pressure, your prognosis is much better, as you could see on the Kaplan-Meier curve in green. If you don't have any of these three bad markers, your prognosis is certainly much better than if you have all of them still present. Everybody knows about the COAP trial. Obviously, a landmark, approach to treatment of secondary mitral regurgitation. And the reason for it is before, a surgical approach has really not panned out. We have multiple trials of surgical approaches, and you could say maybe in the surgical approach is the price you pay for the surgery early on, right? Because here you don't pay a price early on from a negative outcomes point of view. But I think the data is very important, not only from a hospitalization for heart failure, but also for mortality, as opposed to the MITRA-FR trial where there was no improvement, neither in hospitalizations or symptoms of heart failure, nor death. If you look at the major differences between these two, EF is about the same, and the others are different. The severity of regurgitation was larger in COAPT, which was powered probably even more with two times the size of the patient population. Therefore, the regurgitant volume was higher. And remember, this is secondary MR, so you're not expecting a 60, 70 milliliter regurgitant volume. And the LV size was small compared to MITRA-FR. And the concept of Disproportionate mitral regurgitation was advanced by Paul Grayburn and associates from just north of here in Dallas. And what is this concept? This concept is, in secondary MR, particularly ventricular, the ventricle is enlarged. And I have mitral regurgitation with it. Is it proportionate to the size of the ventricle, or do I have much more mitral regurgitation compared to the size of this ventricle? And you could see, and this is a theoretical approach. That theoretical approach, you could see that end-diastolic volume is fixed in a way, ejection fraction, regurgitant fraction, you name it, okay? And this is where coapt falls in the more meaning that the ventricle is smaller and the effective regurgitation orifice area is larger compared to mitral FR. Comes a new study published last year, the Reshape Heart Failure, which may reshape a little bit of our approach. And in this Reshape, it says between moderate and severe mitral regurgitation, again, secondary MR. However, the vast majority are moderate to severe. Very few, if at all, were in the severe range. Interestingly enough, effect on mortality was little. Most of the effect is on heart failure and heart failure hospitalization. So if you compare these three, the major difference is not in age, renal function, which obviously a prognosticator per se, heart failure marker, NT-proBNP, ejection fraction, walking. The major difference is an effective regurgitant orifice area. And the smallest, actually, mean is with the Reshape trial. So it gives us maybe more hope that indeed, even if you aim for moderate MR in this very sick population, you may have a positive outcome. The positive outcome may not be ultimately in survival, but it could be recurrent hospitalization, heart failure, symptomatology, et cetera. So if you plot the three together, right, on that same disproportionate MR, you could see where coapt is, right? More MR, smaller ventricle, effect on almost everything. Mitral FR, which has much bigger ventricle, and these are median, so you can have quite a few large ventricle with moderate MR. But this is more moderate MR, a smaller ventricle with a positive outcome for hospitalizations and symptomatology. So conceivably, the bar could be lower, conceivably. I mean, obviously, these are only 3 trials with a ventricle. So it may tell us that the ventricle, in addition to some severity of MR, may be more important than just having severe MR per se. And the question is, you have the spectrum from MR correction is quite beneficial if the ventricle has not remodeled significantly to the ones who are actually remodeled too significantly and may need actually transplantation. We can't ignore, obviously, good medical therapy in addition to resynchronization therapy if patients need it with significant dysynchrony. So I want to share with you everything you guys know about the complexity, but I think it's important to do that because, yes, we talk about MR, but in secondary MR, it is quite complex if you look at ultimate prognosis, right? Severity is important, right? The extent of remodeling, it looks like, also is going to be important. If you have too big of a ventricle, dilated, too remodeled, it may not help you. Symptoms are important: medical therapy, dysynchrony, RV dysfunction and pulmonary hypertension. You don't see much of that in the trials. Importance of tricuspid regurgitation, and all the comorbidities, obviously, which can affect significance of your outcome if your outcome is not only purely hospitalization for heart failure, but mortality from any cause or cardiovascular causes. I wanted to share this with you because this is important. This is prognosis in secondary MR by incremental quantitative MR severity. In red, which is the top, no MR. This is the prognosis of patients with secondary MR. Mortality more than 50%, obviously, at 10 years. Okay? If you add a tad of MR, and this is effective regurgitant orifice area 0.01 to 0.09, any mitral regurgitation, which we know is also important if you have an acute myocardial infarction, any mitral regurgitation gives you a worse prognosis, which could be because the ventricle, now I have MR, the ventricle may be a little larger, I may have other things, right? Obviously, in this situation, if you correct mitral regurgitation, you're not going to improve that particular outcome from your intervention. And all the others below are increasing severity of mitral regurgitation all the way to very severe. So you have a gradation from none, trivial, mild, moderate to severe, and severe. Okay? And the big question is, where is good for our interventionalist, right, to go after, knowing the complexity of mitral regurgitation? And we put an editorial, Chandra and I put an editorial in JACC Imaging as to what's the next frontier in this situation. Is defining the severity beyond which interventions can alter remodeling and prognosis. It's not very clear at this stage. We have 3 randomized trials telling us that the ventricle is very important, but we don't know where MR severity is going to play. If we take care of that MR severity with all the technology that we have nowadays, that you would improve the outcome of patients. So what I wanted to share with you basically is actually the heart team approach nowadays. You know, we're privileged to have an amazing heart team here. And the beauty of it is actually this heart team concept, which started close to 12 years ago or something like this, is really everywhere, is global. They are in the recommendations of any guideline because things are complex. Some heart team have actually patients with them to be the patient advocate in addition to the imager, the interventionalist, the surgeon, and any other specialty. And I think it's very important, but obviously we need more data to try to refine it. We've come a long way, no question about it. Thank you very much for your attention. Questions?
Dr. Zoghbi.
Yes.
So, as you were going through the lecture, the thing that intrigued me is the depth and the breadth of information that needs to be taken into account, be it ventricle, atrial, valve, flow, function, and so many domains. Most of the outcomes and the data and the managements, as you have shown, are usually been based on 1 or 2 of these variables. So the first question is, do you think there is a future of multi-comprehensive information that can give us more idea about the valve, function, outcomes, management? And I know that at ESC you gave a wonderful lecture around the future. That's where the echo would be heading. What can we do as a community to train our future generations to meet those needs where there's going to be this comprehensive information that may be needed to take into account?
Thank you, Khurram. Obviously, this is a complex situation. I think the one that is more complex is secondary mitral regurgitation compared to the primary one. I think primary one, if it is amenable to surgery, the trends are intervene early, remember, we're talking about, and I say that for any valvular heart disease, be it aortic or mitral, is these conditions that we're talking about, we're not talking about acute MR, we're not talking about acute AI, right? These are chronic situations, and I think we, the medical community, has to be a patient advocate if we are somewhere in a smaller city, be it here or any other nation, and there is a place where people can repair a valve that is repairable, or have diagnostics that are better than our place, I think we should be, all of us, patient advocates and give the best to our patients. They'll always come back to us one way or another, right? And we'll take care of them, but I think they would value so much that we're sending them to get the best of care, although we may not have it locally. And so this is for diagnostics, for intervention, for whatever it is. Now, yes, we could refine this further. From a diagnostic point of view, actually, all the imaging modalities are really amazing, looking at the future of what you could do in rural America versus here, much portability, availability, and I think AI is going to be very important. I didn't mention AI here because between us, it really has not helped as much in refining who is going to be benefiting much more. It converged to most of the things that we just talked about. So how do we address this complex thing? Our trials nowadays have taken 2 or 3 criteria to try to address them, hoping that randomization will take care of all the other comorbidities they have, renal function, various areas, etc. But this is a first step. We're going to have to take a look at that because randomized trial is going to look at this particular patient population and not necessarily what we're dealing with every day, which is much more complex. These are older individuals, have much more comorbidities, etc. So I could see trials expanding, their criteria, but in truth, you're going to look quite a bit also at a combination of big registries that will give us a signal one way or another, with all their limitations, and hopefully some randomized further trials, particularly in secondary MR, where interventions beyond surgery are making a difference in addition to medical therapy.
Dr. Zoghbi, thank you for a very lucid and practical presentation. As always, I think we've done state of art for mitral valve a few times, and every time it's more information that we learn. My question is specific to the secondary MR, and as you alluded, we know MR is hemodynamic dependent. And when you further risk prognosticate the ERO, have people done a blood pressure dependent ERO that you're getting? Because sometimes you have patients who have a high blood pressure, your ERO is high. In them, your GDMT might actually have a better prognosis. People with low blood pressure and ERO probably need to flip. Now I'm sure across the globe, not many labs might be getting blood pressure at the same time. And if people have not done it, I think our lab is one of the few which does blood pressure. So I'm not sure if that layer of risk prognostication has been added.
And the recommendations in most labs, the question is, how often it's done, but most recommendations in echo labs is actually to have a blood pressure taken, hopefully at that time, right? As opposed to recording it from other time. I don't think people have looked at that relationship per se and see if an individual has a higher pressure. And yes, it will be higher, no question about it. That's your driving force. But interestingly enough, in the vast majority of these secondary MR with an EF of about 30% or so, the pressures are on the lower end. If you take a look at most of these trials, yes, you may have some with a little higher pressure than others, but I think it's always valid. And from a clinician's point of view, if you see such, these are the individuals who usually tolerate more therapy, right? And hopefully you may not need an intervention because it is very dependent on size, right? Size and function. Any other questions?
So I have a question.
Yes.
So as you have an amazing presentation as always, and I always learn a lot. So one question regarding the Barlow's disease, and you mentioned that we recently started giving the percentage component of prolapse in the overall MR in cardiac MRI. So what will be the implications? For example, there
severe MR with mild prolapse maybe 20% versus severe MR and prolapse component 80%? What will be the implication for the management?
Obviously, if MR is severe, it is severe already, right? You see this prolapse volume, and obviously we have the experts right here, come into play in typical Barlow disease where you have bileaflet prolapse. In a single leaflet prolapse, that volume is so small that may not necessarily be of importance. I mean, that volume, that prolapse volume can be up to 25, 30 cc's or so. On average, and those bad ones is about 15 or so, 15, 20 cc's. So if you add that to your mitral regurgitation per se. So if you're a clinician, I would look at both. Look at the remodeling of the ventricle, look at the remodeling of the atrium, clinical symptomatology, etc., and take that into consideration in your overall severity in that particular disease. Dr. Shah has a comment. Dr. Lowry.
Great talk, Bill. Just on the topic of global longitudinal strain and the hyperdynamic left ventricle.
Can we fix that microphone?
Is that working? Just in regard to the hyperdynamic left ventricle, it's routinely reported after mitral valve repair that the postoperative ejection fraction usually falls by about 10% in the hospital stay. And this is seen primarily in terms of incidence and severity as you go from the hyperdynamic group down to the lower ejection fraction. And in the lower ejection fraction, we'll see it as much as a reduction of 20, 30% in some people. Interestingly, this has also been reported in the MitraClip literature. So it's not just a surgical arrest of the heart problem. It seems to be a true hemodynamic problem. But the interesting thing, the reason I mention it is to reinforce your point that it looks like a hyperdynamic ventricle is the ideal time to operate, because we've been looking very closely at these parameters in a group of over 1,000 people. We've now got echoes in a lot of them out to 10 years, 15 years. And the hyperdynamic group don't experience this. So the hyperdynamic group do not drop their ejection fraction at all. So the hyperdynamic group is probably the only group that truly has a normal ejection fraction going into surgery.
Very true. Deepen? Dr. Shah.
All right. First off, Bill, thank you so much. Outstanding presentation as always, and congratulate you for the years of work that you've done on this field from really the start. My question for you, you showed nicely how the ESC guidelines, gave criteria in primary MR for when to intervene. But they're kind of assuming all patients to be equal. Do you think all men versus women, the 80-year-old lady versus the 60-year-old man, do you think all of them are equal? Do you think in the future we're going to go to more personalized guidelines? Will we take into account these additional factors? Because maybe the 80-year-old lady may not get to 60 cc's of mitral regurgitation before she gets symptomatic. She may get symptomatic at 40 cc's. And so do you think we're going to evolve to kind of an additional dimension beyond kind of still the one-dimensional approach that we have right now?
I mean, some of that is taken, obviously, always you individualize the guidelines to a particular patient. Not every patient will fit these guidelines, but I think these guidelines overall are good, I think, from an overall umbrella, if you will. The 80-year-old may be symptomatic earlier because of compliance issue. Compliance not only of the ventricle, but also of the atrium, right? There's fibrosis. They may have atrial fibrillation with a atrial myopathy. They may have underlying pulmonary hypertension to start with. So I think each individual patient will be individualized from a therapy point of view. It's hard to put in a guidelines to try to do this, but I think you have to look at also the risk of an intervention. Nowadays we have percutaneous techniques I just referred a patient who was 93 years old. Amazing, who was functional and did very well with a percutaneous approach. So, I mean, you have to individualize, but I think I endorse these guidelines because also they're realistic as opposed to, and hopefully also the ACC will come up with, re-bring some of this. Because their rationale was, it's severe. These are the ventricular, adaptations to the volume overload. That's plenty, meaning operate early. However, some of these criteria are variable, and I think it's good to have other indicators that are clinical that would help alert you at least to significance of the disease. All right. Thank you very much for your attention, and have a wonderful year.